Hi everyone, my name is Vlada. We're excited to be here in person. I don't know about you, but for me, it's the first talk in what seems years, so bear with me. I'm a postdoc at MIT. Before that, I was a postdoc at CIS at UniMelb with the aforementioned Karen Vespoor, who is now the dean at MIT. So I kind of moved with her, but I have a technical background, and this project was initiated at the University of Melbourne together with our colleagues from Origin, which is a suicide prevention organization. And so the project is about detection of self-harm and suicidal ideation in emergency department triage notes. We've recently been accepted for publication at the Journal of, what's it called? I should really know the name of the journal. American Medical Informatics Association, JAMIA. You're probably familiar with that. So that's quite exciting. And yeah, so I'm going to give you a bit of a background about what's happening and what are we trying to do, an overview of the data and our approach, and then walk you through the methodology that we used and obviously show some results. But first thing first, you're probably all very used to seeing daily numbers of COVID cases. These are some numbers that we don't really talk about nearly enough. But suicide, at least before COVID, this is according to the Australian Bureau of Statistics in 2019, before COVID, suicide was the leading cause of death for people in Australia aged between 15 and 44 years. And on average, it claims 9 Australian lives every day. What's arguably even more concerning is that for every death by suicide, we get about 300 people hospitalized following an episode of self-harm. So what does it mean to us? It means that detecting self-harm offers some opportunities to improve patient care at both individual and population levels. At the individual level, we could provide timely mental health support. For example, if someone comes to an emergency department with some cuts or wounds, we don't just stitch them up and send them home. Maybe we organize or arrange a consult with a psychologist. Maybe we start a mental health plan or something like that. At the population level, it allows us to better understand the burden of suicidal intent and support public health initiatives related to suicide prevention by allocating or expanding the resources provided by these initiatives. So self-harm presentations really to emergency departments are a useful proxy for us to evaluate suicide prevention measures. A brief workflow, what happens at an emergency department. This is a very simplified flowchart, obviously. I basically throw out everything that's not relevant to this particular problem. But what happens is roughly a patient presents to an emergency department. They get assessed by nurses and triage depending on the severity of their condition. And this process produces the earliest form of documentation, nursing triage notes. And then a patient gets either admitted to the hospital or discharged following a consult with a physician. And then later on, the information collected during this encounter is coded, assigned diagnosis codes, also known as ICD codes, by dedicated coders. Now, it's important to note that coding is done mostly for billing and administration purposes. It's not done by physicians, and it's also usually performed sometimes weeks after the encounter occurs. All of that makes case classification using ICD codes quite unreliable. The problem is we don't have a single ICD code for self-harm. rather the definition, the existing definitions vary, and they rely on a combination of codes for intentional self-poisoning, for accidental poisoning, or for self-inflicted injury. Sometimes they also take into consideration clinical notes that were produced during the encounter. So it's really quite biased, obviously, and there is a considerable delay in code assignment, as I already mentioned. It also sometimes is unclear whether the injury was intentional or accidental. And as you can imagine, for billing purposes, it doesn't matter really. It matters that it occurred, it matters what was done to fix it, but it doesn't really matter what was the intent behind it. So as a result, we end up with sensitivity in identifying suicide ranging from 13 to 65%. And the sensitivity for suicidal attempt is about 19%, which is really, really low. So only 19% of clinical notes indicating suicidal attempt are associated with a corresponding diagnosis code. So what we thought we can do, we thought we can use nursing triage notes directly to detect self-harm in emergency department presentations, bypassing all these codes produced later, just extract the raw triage notes and work directly with them. This is an overview of our workflow. So we extracted all emergency department presentations to the Royal Melbourne Hospital from 2012 to 2018. And this amounted to nearly 500,000 of emergency department presentations. These records were then manually annotated for self-harm. So the textual component of each presentation was reviewed by an expert in suicide prevention and labeled either positive for self-harm or negative. And I just want to pause here to, I guess, acknowledge how much of an effort that was. Just the first run of the annotation process took nearly 1,000 person hours of work. The whole annotation process with audit and adjudication and review of gray area cases took about 9,000 hours. That's more than a calendar year. So when Karen heard about the amount of data that we can work with, she got obviously really excited, because that's not something that happens to you too often in machine learning, when you just get 500,000 of annotated clinical notes. And then the rest is easy. It's natural language processing, some steps I'll walk you through, and then the development of an automated classifier to predict self-harm. There is a caveat, obviously, because we wanted to minimize the selection bias as much as possible. We didn't do any filtering. We didn't use any keywords. We used all emergency department presentations available to us, which meant that the data set was heavily imbalanced, with only 1.4% of notes related to self-harm. This complicates it slightly. If you've done machine learning, you know that imbalanced data is much harder to work with than, you know, when it's all nice and equal. We did have to remove 11,000 notes because they were short or empty, and that's basically non-informative. And then we also reserved all the presentations from 2018 for prospective validation. So we wanted to show that our model doesn't just learn well and perform well on the data it was trained on, but then it also can be applied prospectively. And yes, and so this holdout set from 2018 was also annotated for suicidal ideation, which is a somewhat milder condition, but we didn't really intend to I guess, learn how to classify between the two. Rather, we just wanted to see whether there is much of a confusion between self-harm and suicidal ideation. Now, what does the data actually look like? Here is an example of a triage note. Try and understand what's happening there. In general, notes are characterized by lack of grammaticality. They're rather short and rapidly written. So you can imagine a lot of abbreviations and a lot of spelling mistakes, use of clinical concepts, and of course slang, especially for drug names. And here is my attempt to sort of decipher what's happening in there. So OD stands for overdose, you know, CO stands for complaining of, and this is something we had to work with clinicians to, they provided us with sort of a vocabulary so we could at least understand what's happening in there. HR80, heart rate 80, OA, on arrival, all those quite common terms used commonly in emergency departments, but not really in English language or even in clinical notes. So our pipeline, our natural language processing pipeline, consisted of several steps that we took to prepare this data, to normalize it before we could feed it into a learning algorithm. And basically the goal is to reduce the number of unique words as much as possible, right? So your dimensionality is reduced from whatever thousands and thousands to maybe just a few thousands. So the first step was pre-processing, just replacing all the obvious OD with overdose and R sheet with relationship, and L bracket means positive, means left, and double plus VE means positive, double minus VE means negative. So they're really quite efficient in the notations, but you gotta be familiar with it. You gotta speak the language. And then the second step is tokenization, which is something you do to basically just split the continuous line of text into separate words, or what we call tokens, combinations of letters and digits and punctuation. And so then you can work with individual tokens and further normalize them. So I guess that's the result. As you can see, we aim to preserve, first of all, complex numbers. We don't want to split apart 39 and 0.5, but also domain relevant phrases like OA, because it's quite commonly used in the data set. We just want to treat it as a single token. The next step was creating a domain-specific vocabulary. Now, to be able to do further pre-processing, further text normalization, we need to know what tokens, what combinations of letters and digits and punctuation are generally allowed in our context. And the language of emergency department notes uses, of course, general English words, like walked in front of car. It uses numbers. It also uses medical terms, like the word acopic, which means unable to cooperate, and you really can't find it in an English dictionary. Abbreviations like PHX, which stands for previous history, and GCS, which is a Glasgow Coma scale that clinicians use to evaluate your responsiveness to the environment, and then names of drugs. So that was a slightly intricate process, sort of creating this custom vocabulary rather than using something pre-existent. I don't know if you've heard about Mimic. It's a large publicly available database of ICU stays, and they have a lot of free text notes in there. So what we did, we retrieved the vocabulary, learned from this massive data set, and then filtered out all the irrelevant terms from there, and also manually added drug names and names of local mental health organizations like Origin, for example. And that resulted in 36.5 unique words. For comparison, Oxford Dictionary has probably about 270,000, maybe 2/3 of them actively used. So it's a rather small vocabulary compared to the whole English language in general, but still quite a few different variations. Spelling corrections. Now, this vocabulary that we've customly created, we then used to correct spelling. And the challenge there was that misspellings occur both in common words, but also in very specialized medical terms. If something is if a word occurs in your data not very often, and then half of it is misspelled, it's really difficult to learn which one is the correct version and then to fix it everywhere in the data set. So some common mistakes were due to, well, I call it a fat finger syndrome, but really it's just because they 4 and E and 3 are kind of collocated on the keyboard. So, you know, you try to type instead and you end up with a 3 inserted in there. Or for example, the first one is pain. So again, P and a square bracket are next to each other. So you end up with this. But also genuine mistakes like spelling the word agitated. You think, how many ways can you misspell the word agitated? And you can see it's pretty impressive. And the list goes on and on. So what you want to do, you want to convert all of these to a single word, maybe to agitated and agitation, if you like. But you really want to reduce this dimensionality to something more feasible. So our spelling correction worked pretty well. We found and corrected 60,500 unique misspellings. So that's just unique misspellings. Obviously, a lot of them are repeated throughout the whole corpus of data. And then the final step was synonym integration. The same drug can be referred to by different names, which is not very convenient for us as, I guess, computer scientists or natural language processors, but that is what it is. So alprazolam is the generic name of a drug. Brand names are Alprax and Xanax, which is, you might be familiar with it. It's a common antidepressant. And then Xanax is a slang for Xanax. So given the context in which we're working, detecting self-harm, the evidence of drug abuse is especially important, obviously. Even more so when it comes to antidepressants. So that was sort of almost a manual process where we replaced all the, I mean, still automated, but we just provided the computer with a list of synonyms and replaced all of them by a single name. As a result of all these steps on the right, the dimensionality of the vocabulary went down from 100,000 words to almost 44,000. So that means that the number of features we feed into learning algorithm is about 44,000. Still a lot, but considerably less than it was at the beginning if we were using raw text. We tried some additional transformations that in the literature were found to be helpful. The first one is clinical concept recognition. When you map individual tokens to medical concepts from a knowledge base, we used the mesh knowledge base. Basically, it's another attempt to unify synonyms and phrases that relate to the same concept. Bigram replacement, when two words occur very commonly, you kind of want to treat them as a single, again, as a single concept. So for example, chest pain. And negation detection, where we replace a token with, well, you can see alcohol is replaced with neg alcohol because it's negated in the sentence. So we kind of want to take into account that there was not any alcohol consumption. Disclaimer, none of it really improved anything. So I didn't even include the result. I mean, I included them in the supplementary material, but these are very common techniques in natural language processing. Some of them gave really good results in clinical notes, but in our case, just no improvement, sometimes even impairment of the performance. Yet, of course, we had to test all of them. So it's a slightly weird diagram, but basically we had the output of our NLP pipeline, and then we tried different combinations of these 3 additional types of transformation. And then we also tried 3 different types of learning algorithms. One is keyword search, where you learn words associated with the outcome, and then in your validation data, you try to find these words and basically label a note as positive if you have any of these words present. Machine learning and deep learning. I'm not going to go into details because if you know it, you know it. If you don't, you probably don't want to anyways, and it's 9 a.m. But the keyword search does not normally work, and it didn't really work well this time either. With machine learning and deep learning, it was roughly similar, but deep learning takes a lot of time for training, and it's much harder and more complicated and less interpretable and whatnot. So we sort of abandoned that. I mean, we showed that the results are similar. Why would you go for it, right? You want to go for something simpler. So our best results were achieved with a gradient boosting model, which is not great either in terms of interpretability, but I guess at least it's you can train it in a few, maybe in a minute or so. And this is the result on the test set. So we get the positive predictive value and sensitivity of 80%, and then specificity is almost 1, which is a pretty good result. We got very similar performance. I didn't include it here, but we got a very similar performance on the prospective data set. If you remember, we reserved the data from 2018 for prospective validation, which was great to see too, because it means we can use our classifier prospectively in the new data. And then on the right-hand side, I included a couple of examples. An example of a false negative note. So, okay, so the words highlighted in the text are the features that were most important for this particular example. So in the first one, in the false negative note, you can see that took approximately tablets, and these are all obviously related to self-harm. However, the note was predicted as negative because its probability was just below the cutoff. It's one of those instances that you kind of sacrifice in order to get fewer false positives. The false positive, the example of a false positive note also contains suicidal and intent and tablets and packets that are all positively associated with the outcome. However, it wasn't annotated as self-harm, but it was annotated as suicidal ideation by our clinicians, which means that there is some confusion between the two groups. Obviously, as you would expect, they use similar language. So if we want to I guess, develop a classifier that would distinguish between negative notes and suicidal ideation and self-harm, we probably need to collect some more data to be able to learn the very slight differences between self-harm and suicidal ideation. Future directions would like to include demographics data. I don't know if you noticed at the very beginning, I showed that about 300 people are hospitalized following an episode of self-harm. Out of them, 280 are women. So, and like 36 are men or something like that. So gender or sex, I don't know what's the right term nowadays, but is obviously important in terms of predicting self-harm. We want to be able to detect suicidal ideation cases. We want to test our model on other hospitals. So we're working with Western Health and La Trobe to acquire the data and to see whether we can perform as well there. And then finally, we would like to test our tool for surveillance in 2020-2021 and see how the rates change, the predicted rates change, maybe with the introduction of lockdowns in Victoria and changes in restrictions. Because there's been some research coming out from New South Wales that there are actually quite noticeable changes where, at least in 2020, that first the rates kind of went down because people were reluctant to go to the emergency departments, being scared of COVID, but then the rates went up and further up than the baseline because lockdowns and restrictions started affecting especially the younger generation. Acknowledgements, our Dr. Katrina Witt, who went through 500,000 records, Joel Aldenson, who is, I think, the chief investigator on this project, Karen Worspoor, with whom I work and who supervises me, and then Jan Lee, a student from UniMel, who kind of started the initial works on this project. Thank you very much. Yeah.
You mentioned in the end looking at the data for 2021, maybe differently with COVID. But earlier you used 2018 to separate yourself for hospital validation.
Yeah.
Have you considered the possibility that change of practices along the year would have tainted this data and instead using a random selection of data points instead of a yearly cutoff that is more robust?
So I think with the changes in policies, we don't expect much to be changed in regards to how self-harm cases are managed. There might be some change in the language for sure, like you would expect some mentioning of having a cough or runny nose or COVID and again and again and again. So I think that's a good point, and there might be some need for some further refinement of the model, or even maybe retraining it on, or further training it on a part of chunk of data from 2020, 2021 when this kind of new phenomenon occurred. Sorry?
Keeping up with drugs.
Yeah. Yeah. I mean, that happens every time when a new drug is introduced as well, right? If something comes out on the market that's an antidepressant that's widely prescribed and you've never heard of it in the past 10 years, you'd need to introduce that to the model and for the model to learn this new word to be able to capture these cases. Thank you.
I thought it was very impressive the amount of data you collected and labeled. It takes a huge amount of effort to properly label that amount of observations. Something I was wondering, how many annotators work in this process? And also, do you have data what was the agreement between different annotators. It's important to see what a professional would think of the data. But also, not train a model just to the bias of a single annotator or some data. Have like a holistic view of different perspectives.
Yeah, thank you. Yeah, that's a good point, and I totally agree with that. So I think due to the amount of data, we couldn't really afford having multiple annotators going through the whole corpus. As far as I know, one annotator went, so Katrina went through the whole corpus, and then they had a sort of meetings reviewing every chunk of data with other experts kind of agreeing on gray area cases. And there were also parts of the data annotated. I think it was actually in the prospective data set that were annotated by the second annotator, and the agreement was 0.91. That's pretty good. Not perfect, but we reckon that's good enough for us to rely on the data the way it is. It's really like going through it again would be hell.
Yeah. It's understandable. It's very expensive.
Yeah. So I think Katrina trained the research assistant, and then they kind of went through it individually, obviously blinded, and we compared it with 0.91. Pretty good. Thank you. Yeah.
That was fantastic. Thank you so much. There's sort of a broader question of the potential extension of the work, because across mental health services, the reality is we're terrible at predicting suicide. We're not bad at predicting self-harm. I'm just wondering if there's any potential for positive flagged instances to be linked to future coronial data. So of those that are flagged, and I mean, the reality is you need a massive data set that you're I think expanding to other hospitals using the model to really refine, because I think the long-term value of the targeted screening for more reliable understanding of future suicides is a little bit of a holy grail to actually get there. So I'd just be interested if that's the potential on the cards. I know Joe Robertson's doing some work with coronial investigation data as well, but if it could be linked to cases from this, I think it could be remarkable.
That's very interesting. Thank you. I actually wasn't aware of Joe working on it, and yeah, I don't know if they've thought about it. I also don't know whether there is a general data set across Victoria, or would it be per hospital? In theory, it's possible. Obviously, you can acquire these sort of labels and try and link the predictions of these classifier to the actual cause of death later on.
Or the coronial data set to then retrospectively see if there's access to emergency data.
Yeah. I think there are a few challenges with that. One is you would want to take into account the time between the emergency department encounter and the actual event of death. The other thing is this classifier was developed with a thought of using it as a surveillance tool rather than a screening test. So it's, I guess you would want some higher sensitivity and specificity, specifically, to be able to use it as a screening tool. But it's a very interesting idea. Yes, why not go further? And someone comes to an emergency department, kind of flag them in the system and keep an eye on them.
I think the applications would improve current screening tools.
Yeah. Thank you.
Well, this could be also a question that I received by Twitter. I think kind of already answered. You said Katrina led the annotation and
Yeah.
So this person asked whether the experience advice is involved in annotation of suicidality and
So sorry, could you repeat?
Like, the experience advice, people who may be in that situation themselves. So it's really just two people who just said that.
Yeah, I'm not sure. I mean, these are trained researchers working in suicide prevention, so I would rely on them more than anyone with experience.
I don't think how maybe actually between one had some researchers in the US that have actually involved some experienced people in annotation. But yeah, it's like, well, truly, start off with someone treating an expert.
Yeah. I wonder how is it ethically involving someone with a lived experience in annotating?
There's actually a Zoom stream happening, so some people watching
Thank you very much.